Okay, is it problem?
Yeah. Lavanya, please switch on this slideshow and we can start now.
Okay. Good evening, everyone. Welcome to the Higgs Journal Club. Today we'll be speaking about IDEAL-ICU trial, a sub-study of it, which talks about the differential effect on mortality of the timing of initiation of renal replacement therapy according to the criteria used to diagnose AKI. To go through this, we have the speaker today, Dr. Lavanya from Medicover Hospitals. Lavanya, over to you.
Thank you, ma'am. Myself, Dr. Lavanya. I'm a DRNB resident at Medicover Hospital. So I thank Samvedam sir and Gansham sir for giving me this opportunity to present this JC. So today's topic will be an IDEAL ICU sub-study. So actual IDEAL ICU study was published in 2018, and this is a recent study which was published in. It's a post hoc analysis of IDEAL ICU trial, which was published in August 2023. So this says that there differential effect on mortality of the timing of RRT initiation according to the criteria used to diagnose AKI. So over last 2 decades, multiple trial studies have been published comparing early delayed RRT initiation in AKI patients. But even now, with all the high quality studies, RRTs, there was no precise criteria that is available to use in clinical practice. So if there are life-threatening complications, all of us know bedside, we think if there is a life-threatening complication like metabolic acidosis or hyperkalemia, we know that, or pulmonary edema, we know that we have to dialyze that patient. But when that is absent, what to do? It is still uncertain. So if we think, if we do an early RRT, the patient can benefit in terms of electrolyte and acid-base control and fluid balance. But does it clinically apply? Theoretically, it is true, but is it really true? So over last 2 decades, there are multiple trials, out of which the important studies being ELAINE study in 2016, followed by AKI IDEAL.
Lavanya, your slides are not moving, so please go back to the slide sorter and change the slides on the left side. The slides are not moving, so please go back to the second slide on the slide sorter on the now it's now it's fine. But the slideshow is not on, so only the slide sorter view is being seen. Anyway, you carry on, don't stop.
Not able to see the screen right now, so just one second. So, yeah, can all of us see, sir, right now?
Go on.
Yeah. So over last 2 decades, so multiple studies were done, out of which the important one, ELAINE study, actually said the earlier RRT is done, it is associated with less mortality. There is a decreased mortality as per their study. Eventually, AKI IDEAL ICU START AKI trials have been conducted and published, which have not shown any difference in the primary outcome, that is mortality in 90 days. So, and also there is another study, AKI2, which was published in 2021. So is whatever ELAINE study told, is it actually, can it be applied in clinical practice? The limitations being it was a very small sample, included only 230 patients, and it was a single center study. And mostly they have taken surgical patients. So further confirmation was required for the study, and these further studies like EKIKI, IDEAL-ICU, START-AK, they have not shown any significant difference in as per mortality when there was an early RRT being initiated. So further studies were required to confirm the benefit of early versus delayed RRT. In EKIKI 2 again, they had a very small sample, that is 278 patients, and they've used 1 levels as the for RRT initiation. So is it really worthwhile to follow this study? Still no, because significant limitations are present. Now, so all these studies, they have used one of the criteria of AKI diagnosis. Whether it is rifle criteria or KDIGO criteria, and all recent studies have used KDIGO criteria. So slides are moving now.
You need to click on every slide on the left side, then only they are moving. So you please click on the slide sorter on the left side, and each slide will move. You need to click on those thumbnails which you are seeing on the left side.
Yes, sir.
Yeah, then it will move. Because it's not in the, yeah, you click that, it will move.
Okay, I'll keep doing this.
Yeah.
So the diagnostic criteria being used in all the studies, either rifle, the failure stage, or KDIGO stage 3. Most of the studies have used these criteria. So as per 3 criteria of AKI diagnosis, almost the urine output criteria remains same in all 3 stages. And as per the creatinine criteria, there is a slight difference in each one. KDIGO, the recent most the criteria that we have been using, stage 3, more than 3 times of baseline within 7 days, or absolute increase to 4 mg per deciliter, with an acute increase of more than 0.5 mg per deciliter, or an initiation of RRT has taken place already. They fit in stage 3. So all these studies, are they were they really about were telling whether early versus delayed is beneficial or what? Or they're trying to actually test the potential of this AKI diagnostic criteria? So it was more like they were trying to test the potential of the criteria. Our study now today, topic of discussion is IDEAL-ICU. Before going to the sub-study that is recently published, I would like to go through the actual study. So where in that they've taken the severe AKI at the failure stage of rifle classification system, but who did not have any life-threatening complications related to the AKI. So they have subjected to these patients in early strategy group within 12 hours of the documentation of failure stage. They have subjected them to the RRT, and later delayed strategy, they delayed for 48 hours if there is renal recovery has not occurred. So with this study, they wanted to see the primary outcome of death at 90 days. The results, this study could not be completed because there was a futility of the study. They had to stop in between, and they have studied 488 total patients, out of which 9 patients data was missing. Hence 477 was included in the final study. So out of which the results being 58% of the patients in the early strategy group, they had the 58% is the mortality in early strategy, and 54 in the delayed strategy group. So in the delayed strategy group, 38% patients did not receive any RRT. And criteria for emergency RRT was met in 17% of the patients of delayed strategy group. So out of this, they have concluded that because the mortality death percentage was almost similar in both early and delayed strategy group, they have said that there is no significant difference in overall mortality at 90 days between patients who are assigned to early strategy and also the delayed strategy group. No, so because there was no statistically significant difference in the mortality between both the groups, still the question whether there is a benefit of early RRT is still a question mark. So maybe all these studies, HEK, START AKI and IDEAL-ICU, the conclusion, there is a variation in the choice of inclusion criteria. Maybe they have not identified the patients who have actually had a severe AKI form or renal failure form, and who actually potentially may benefit from early RRT. So still the question remains whether can acute kidney injury diagnostic criteria, whether early is better or delayed is better. But can AKI diagnostic criteria modify the impact of the timing of RRT, whether it is early or delayed? That is the question of this study. So in this sub-study of IDEAL-ICU, they have hypothesized that in patients where AKI diagnosis is solely based on creatinine elevation and also solely based on urine output criteria or both of these criteria. So they thought the severity of AKI in these three groups is different, and thereby the impact of early initiation of RRT, that is the mortality rate, is different across these groups. That is the hypothesis before starting. So how they have the study is same, the IDEAL-ICU study, which was done in 488 patients across multi-center study. It is a randomized control study over 29 ICUs in France. The same data was taken and the post hoc sub-study was done from the same data. Initially, when they took the inclusion criteria, it was a failure stage of rifle classification, and they were divided into, they were taken as an early or delayed initiation strategy, out of which this sub-study has taken stage 3 of KDIGO classification, which is almost like a rifle failure stage. They have further divided the groups into 3 groups based on the diagnostic criteria of AKI. And first group included patients who were enrolled at the time of randomization or enrollment. If they are taken based on creatinine elevation alone in group 1. In group 2, reduced urine output criteria alone. And in group 3, both criteria were included at the time of presentation. So after dividing into the 3 groups, that is creatinine alone, urine output alone, and both criteria, and 2 arms, that is early strategy and delayed strategy in each group. Early strategy, they are subjected to the RRT within 12 hours. Delayed strategy, they waited delayed for 48 hours after the diagnosis of AKI. If there is a pre-specified emergency criteria, like there is a hyperkalemia, potassium of more than 6.5, metabolic acidosis, pH of less than 7.15, and if there is a fluid overload refractory to diuretics, and also with pulmonary edema, they have started the RRT immediately in those patients. And the choice of RRT technique being, again, depends where there is varied during which center. It could have, they've either used intermittent or continuous type of RRT, but following the international guidelines. And the endpoints being primary outcome being death from any cause at 90 days after randomization. And secondary endpoints being ICU and hospital mortality, ICU and hospital length of stay, RRT free days, RRT dependence at hospital discharge, and renal function in the surviving patients who were not RRT dependent at the time of discharge. So these they have done statistical analysis comparing early versus delayed RRT with the randomized arms performed. They were done according to intention to treat principle. So, and thereby death percentages were calculated according to the time of RRT initiation in each group. In each group, they have taken 2 arms, that is early and delayed strategy, and the death percentages have been taken. A logistic regression model with the 90-day mortality as an independent variable, it was used to evaluate the interaction term between RRT strategy and the groups. If there was a significant interaction between the groups and the RRT strategy, they've used a multivariate analysis to adjust the factors. So, and the secondary outcomes are described across the groups according to the timing of RRT initiation. So, the secondary outcomes being the proportion of patients with severe metabolic disorders, pulmonary edema, ICU mortality, ICU length of stay, number of ICU free days, and at the time variation in creatinine related to the baseline, and in surviving non-RRT dependent patients at discharge. These are all the secondary outcomes that they have seen. So the results of the study, in this study, actually the patient characteristics have a widely different characteristics. So there were significant differences in the baseline characteristics of the patients. So as we already discussed, 488 patients were enrolled, then 9 patients data was missing, and 479 was the final count. Out of which 205 were there based on the creatinine elevation only diagnostic criteria. Group 2 is 174, that is reduced urine output criteria. 100 patients in group 3, that is combined criteria. So if you look at this patient characteristics, in group 2, chronic renal failure and chronic liver disease, the percentage of patients and the numerical is high in group 2 compared to other groups. And the nosocomial infections were high in group 2, that is reduced urine output only criteria. And also SOFA score being little higher in the group 3 compared to group 1 and 2. So there is a significant difference in the baseline characteristics of all 3 groups. That may be one of the limitation of the study. And also, if we look at the serum creatinine before admission, is higher in the group 2 criteria, but at enrollment it is higher in the group 3. So there's, as per this table, we understand that there are significant differences in the baseline criteria as per SOFA and the other coexisting conditions. Hence, if there is a significant differences and there is an interaction, they have done a multivariate analysis, center-based strategy, and other characteristics including SOFA and other coexisting conditions, they have adjusted with among the groups. And primary endpoint of the study showing in early RRT group, in group 1, early RRT, patients who received 104 patients received early RRT. 57 out of 99 have died in early RRT group. That is percentage of 58% mortality, and 42 out of 100 died in the delayed RRT group in group 1. That is 42%. From this, we can they have said that it is a statistically significant difference is present. Hence, they told in group 1 in early RRT there is increased mortality when the group 1 being creatinine elevation only diagnostic criteria. If they have used reduced urine output only criteria, out of 84 patients, 48 died in early RRT group, and 59 out of 88 have died in delayed RRT. In both criteria, if you have taken almost a significant, the difference was, the mortality was almost same. If you see in the group 2, the percentage of mortality in early RRT is 57% and delayed RRT is 67%. So from this, we can say that absolute increase in the mortality is present in delayed RRT in group 2. But it was not statistically significant. So it may be clinically significant, but statistical significance has not come as per the study. So also because as we were told, there is baseline characteristics, there was significant difference. There was a multivariate analysis that was done associated with 90 days mortality. Still, with all the adjustment and multivariate analysis of the association between RRT timing and after this also, there was a significant increase in mortality in group 1, that is creatinine elevation only group, compared to the delayed arm of RRT strategy. secondary endpoints being total ICU length of stay and ICU mortality. If we look at ICU mortality, it is almost same in early RRT in group 3, that is when combined criteria used. But when we used a creatinine criteria, in early RRT group, the ICU mortality was high compared to delayed RRT in case of group 1. So from these results, we can they indicate that the patients in the failure category of the rifle classification, initially to take ideal ICU has taken a very much the heterogeneous group, that is baseline characteristics of patient have been different. But those diagnosed on the basis of, if we take rifle criteria, it was more of a heterogeneous group. But if we take based on the creatinine elevation alone, they do not appear to benefit from early initiation of RRT, but on the contrary, they may actually have an increased mortality as per this study. Patients diagnosed on the basis of reduced urine output only had a numerically, but as we said, absolute mortality was increased by 10%, but it did not translate it into a statistical significance. So now whatever criteria was used in all the studies, this criteria is not to tell us when to start RRT. It is basically one of the predominant factor, but it should be always dependent on the wider clinical context, where we keep in mind that patients' comorbidities and other organ dysfunctions. So maybe the using rifle or a KDIGO criteria as a trigger for RRT initiation was unlikely to improve outcomes. And they have their own limitations. If we are using a creatinine, serum creatinine and urine output, they have their own limitations. For creatinine, there should be a baseline level determination and delayed peak value. And also relationship with muscle mass, although they are the principal limitations. If we are using urine output, the lack of specificity is the most important issue. But all the patients that were included in the study, probably there was fluid resuscitated in the initial parts of early septic shock and AKI. So probably the specificity is better after the resuscitation. So again, in this study, still they did not provide any formal explanation why there is an increased mortality in the early initiation of RRT in the group 1, that is creatinine elevation alone. Probably the one explanation is creatinine is a time-lagged marker. So it would have taken some time for the creatinine to become normalized. If we are taking a reduced urine output as a criteria, they appear to be more severe forms of AKI in these patients, and they are not very rapidly reversible. So like as per group 2, again 10% absolute difference is there in the mortality, but it was maybe clinically meaningful, but statistically not significant. And see, patients in group 2, based on urine output criteria, they had more severe illness and they had a higher SOFA score, and also they had a higher fluid balance. So this explains the severity of AKI in group 2 and the potential benefit of earlier RRT initiation in this group. Probably this is the explanation why in urine output alone group, the early initiation of RRT had a benefit compared to delayed initiation. The strengths of the study, it is from a multi-center study, large RCT. It had 488 patients, which were taken in acute phase of septic shock. And they were all, the groups included were fine-tuned with a specific criteria specifically for the groups. And they have multiple limitations because basically it was not the study by itself. From IDEAL-ICU, they have done a post hoc analysis. So the definition of the groups included in this analysis is initial purpose of the study of IDEAL-ICU was different from this one. This is to tell that the mortality may change with the diagnostic criteria. So it may lack a statistical power since the IDEAL-ICU was not designed for the same purpose. And so also in the delayed arm, what is the trigger for RRT initiation? RRT was usually mandated 48 hours after the randomization for all patients in the delayed arm. this delay may be not long enough for spontaneous recovery, especially in group 1, because creatinine is a time lag. So it doesn't may not reflect actual clinical practice. So in the IDEAL-ICU study did not implement any scales for predicting either worsening or persistent AKI or early recovery of function, like furosemide stress test or any biomarkers for renal function were not included in the study. So the conclusions of this study being, as we have seen, the ideal timing for RRT initiation in the setting of severe AKI, despite all the high quality RCTs, it is still a complex thing. Early initiation of RRT is associated with higher mortality if we take the diagnostic criteria as only elevated serum creatinine. And it shows that among critically ill patients with septic shock, mortality following early versus delayed initiation of RRT is different depending on the criteria used to diagnose AKI. So this particular sub-study is mainly to tell whether there is a mortality difference when you consider a different diagnostic criteria, that is creatinine or urine output criteria. So further research is actually required, and also to include biomarkers and to identify the predictive factors of the need of RRT. So the whole bottom line of this study, so there is the timing of RRT initiation has a differential impact on outcome according to AKI diagnostic criteria. But further studies have to be still confirm this thing, and also the limitations being so many limitations of this study. So there further studies need to be required in this aspect. Thank you, sir.
Thank you. Thank you, Lavanya. I think it was a good review about the subgroup of the IDEAL-ICU study. So the perspective from which we need to look at this particular study is that the first point is, this is first of all a subgroup analysis. So from an interpretation point of view, it is whatever conclusions we may infer or we may draw from this cannot be extrapolated straight away into practice. At best, it can actually provide a hypothesis for further study. That's the first point to remember. Second point to remember is that the original IDEAL-ICU study did not complete the fully scheduled number of patients for which it was powered and designed. It was terminated midway. So that itself is statistically a weaker study. And if you do a subgroup analysis of a study which was initially, which itself did not complete the full mandated number of requirements, the statistical contribution or the statistical relevance of the data that is used for this study does not make much sense. If you keep that aside, the point to remember here is, when you talk about early RRT, there is a difference of opinion between the intensivists and the non-intensivists. So the non-intensivists will look at AKIN 3 as the early RRT, whereas the intensivists would look at a stage between AKIN 1 and AKIN 2 as early RRT. So if you see, it is very clear that if you initiate RRT in AKIN 1, you are going to do more harm to the patient. So those patients, more than 50% of them would come out without any intervention or without RRT. Just taking care of the hemodynamics, the oxygenation, the fluid balance, and avoiding nephrotoxins will revert more than 50% of those who are in AKIN 1. AKIN 3, if you delay it, the outcomes will be bad. That also we know. So the problem or the gray zone is AKIN 2 patients. And the focus should be on AKIN 2 or the border zone between AKIN 2 and AKIN 3, rather than focusing on AKIN 3 only, where some of the practitioners feel it is late, while some of them feel it is early. If you look at all the studies which you mentioned, which looked at early and late RRT, all of them had a heterogeneous recruitment process. None of them had the single homogeneous entry criteria for recruitment into their studies. So still, as you said, what is early RRT? Which stage of AKI is amenable for benefit with initiation of RRT is not yet known. As you said, creatinine and urine output are functional markers. So when the functional markers are delayed, are deranged, then the reversibility itself be in question. But to date, apart from renal perfusion index and a little bit of cystatin C and Kim in cardiac surgery patients and cardiac patients, no functional biomarker has been shown to be a determinant of indication or an indicator for early initiation of RRT. We all know that the structural biomarkers usually predate the functional biomarkers by close 24 to 36 hours. But we do not yet know which is the ideal biomarker which will identify the right cohort of a broad spectrum of critically ill patients who will benefit with the early initiation of renal replacement therapy. So the structural and functional biomarkers, the debate will, so if we can identify the marker, then this analysis of early versus late RRT also comes into the picture. The other aspect is there is some evidence in small observational studies that younger patients, trauma patients, usually do better with delayed RRT because they have good physiological reserve. The so-called renal reserve is preserved in these patients. So in these individuals, so even if you delay the RRT, they do have the physiological reserve to overcome acute kidney injury. Whereas the elderly, the diabetic, or those who have other risk factors like hypoxemia, hypotension, or other risk factors for acute kidney injury, they probably would benefit from a more aggressive renal replacement strategy. As of now, based on the findings of either the original IDEAL-ICU study or the subgroup analysis, we cannot change our practice of deciding or initiating renal replacement therapy on core indications of oliguria, hyperkalemia, azotemia, and metabolic acidosis. Based on the findings of these two studies, the IDEAL-ICU and then the subgroup analysis, the indications for early initiation of RRT cannot be widened at this point of time. Only if the future will tell us whether we can identify more studies, more data, more parameters on which timing of RRT can be decided. Dr. Jose and Dr. Gansham are held up today, so I think that's all we have. Ravina, you want to say something?
Yes, sir. Like the early RRT group, I think the RRT was started within 12 hours of diagnosis of AKI. I think for the Indian setup, probably the 12 hours is probably much lesser time according to the logistics and all. It will at least take a 24 hours. So do you think that would have been a difference? That would have made a difference in such kind of studies?
See, 12 hours is probably the timeline which most definitions have used for a serial rise in creatinine or a decremental measure fall in or a serial fall in urine output. But having said that, when you see our patients, 12 hours may be too early to say that this will improve or this will not improve. Yeah, so I think you are partly right there, but still, in aggressive units, I think that's what is the truth. 12 hours is what most people would look at in terms of early initiation of RRT.
Why do you think is like the more difference? More is the mortality if there's early initiation in the creatinine only group, the first group comparatively, because there was this is the first group where only the creatinine was raised comparatively. That means the urine outputs were preserved. We are looking at a patient who is non-oliguric and we're dialyzing him early, and the mortality in that group is comparatively higher. So do you think maybe we should not just go by creatinine and just go by urine output rather?
Creatinine is not the most sensitive marker of good or bad kidney. That fact needs to be remembered. Whereas urine output is probably a surrogate of cardiac output and renal perfusion. So when you talk about perfusion, that is what is the be all and end all of resuscitation and organ recovery, whether it's coronary perfusion, cerebral perfusion, whatever perfusion you take. So I would look at creatinine as a more complex test, whereas urine output is a more of a perfusion marker and a pressure head marker. So you relying on the sole parameter of creatinine is probably going to put more patients on dialysis and renal replacement therapy. And early initiation is sometimes known to increase the chances of these patients actually getting not coming off dialysis. So we should use a combination of at least one of these two at least till a good reliable biomarker comes within our reach.
In the second group, sir, where only urine output is something which is less, and the creatinine, I suppose, is normal. So because it's in the second group, if both would be there, it would be in the third group. So in patients who are only oliguric, as delayed RRT showed a benefit in the mortality, though not statistically significant. So if you have a patient in the ICU and if he's like oliguric or anuric for a couple of hours, and would you really delay the RRT for 48 hours by giving him a furosemide stress test or trying to attempt correct his hypovolemia, or maybe?
See, the only contribution or the role of a furosemide stress test in current day ICU practice is to identify those patients whom we should not follow a conservative strategy. It will identify those patients who probably would need to go on dialysis very early. So a failed furosemide test is more important for me than a successful furosemide stress test. So from that perspective, all patients who are fluid resuscitated and probably have some signs of volume overload are oliguric being contemplated for renal replacement therapy should be should undergo or eligible for an FST. And if the FST is negative, then you don't need to delay. Even if the patient is non-oliguric, it does not respond to furosemide stress test, you will put them on the filter.
Irrespective of the results?
No, negative FST.
Negative FST. Okay, so that you think is a better option because delayed RRT has shown better.
So at least this is for patients who have got enough fluid and are fluid resuscitated, and further fluid does not make any change to the stroke volume and hemodynamic indices. In such patients, giving a furosemide stress test will identify those on whom you should not delay the initiation of RRT.
Okay, sir. So are we looking at any ideal time to dialyze when it comes to sepsis related AKI without any background CKD?
See, there is now the whole concept is AKI, CKD is one concept. There is something called as acute kidney disease. So where both of them happen, AKI and CKD can happen. So in a septic AKI, the pathophysiology is multifactorial. There is a toxin-mediated renal injury. There is a hypoperfusion-related renal injury, and there are pharmacological injuries which happen because of contrast. So in a patient with a septic AKI who is catabolic, who is oliguric, I would probably wait 24 hours to see where the vasopressor requirement is going. If the patient's vasopressor requirements are ongoing, I would see that as an ongoing ischemic insult to the kidney. And I would probably support that kidney with renal replacement therapy at the end of 24 hours.
Maybe including another category of metabolic acidosis rather than just creatinine and urine output, would it be better?
So that is the major issue. That was a major issue when all the studies compared early RRT versus late RRT. One of the criteria which people used to initiate early RRT was metabolic acidosis, right? So it did not result in better outcomes. And that gave credence to the bicarb ICU trial, which said that in patients with AKI, the use of bicarbonate to reduce the acidosis might prevent some of them from going on to RRT. So I'm not in favor of this concept, but not all acidosis per se as a standalone indication may not be the right way of deciding who goes on renal replacement therapy. However, an oliguric catabolic acidotic patient is more likely to be eligible for renal replacement therapy.
What if somebody has a worsening acidosis with urine outputs being maintained?
We will wait on those patients. We will find out the cause of acidosis. Is it under resuscitation? Is it hyperchloremia? Is there some other pathology that is going on? An ischemic organ? Whatever is the source, we need to find the source of that acidosis if the urine output is preserved without diuretics.
So before that, would you start bicarb, sir?
No, I would not start
Outputs
bicarb.
are
Which my
maintained.
personal preference is not to use bicarb for these patients. For the reason is I believe that base excess and bicarbonate are subtle clinical signs in critical care medicine, and masking them is to give paracetamol to somebody who has septic shock and say my patient is afebrile.
So to conclude, maybe you will wait on a patient who is actually having good urine outputs,
Yes.
irrespective of the creatinine.
Yeah, definitely yes.
And the metabolic acidosis.
We'll wait on those patients.
And
unless the acidosis is causing symptomatic arrhythmias.
Unless the acidosis is causing symptomatic arrhythmias. If it is, then you will go for the filter rather than the bicarbonate.
Yeah, definitely yes. Because it is bicarb is not calcium bicarbonate or potassium bicarbonate, it is sodium bicarbonate. So you are adding sodium load to the patient, which is bad for critical care patients.
And early RRT would be preferred in?
Early RRT would be preferred in first a volume resuscitated patient who throws up a negative FST, and a patient in septic shock who has ongoing insult, ongoing cause for renal injury with escalating vasopressor support with dwindling output and either acidosis or hypercapnia.
Yes. So we can conclude that maybe early RRT would benefit in patients who are actually oliguric and who has failed their FST.
Yeah.
And you can delay the RRT if somebody is having good urine outputs and probably responsive for FST. And no real role of sodium bicarbonate in the scenarios of acute kidney injury in the sepsis patients.
Yeah. I agree.
Any concluding remarks, sir?
That's it. I've said what I wanted to say. We'll ask Lavanya what she understood.
What about the numbers needed to treat? That was only 477 patients. And would you really...
Any study which has not completed its scheduled recruitment, I'm not going to rely on the NNT or NNH and say it's good or bad. So maybe it should be repeated in a big, because it was withdrawn for futility. So the endpoint, the hypothesis was not substantiated. That's a concern for me. We'll take final comments from Lavanya because she's the one who's done research on this.
Sir, I feel like still as per other studies, this study also did not say, how to put this into clinical practice. As a student, as far as what I have understood, as per what was always tells is like, extrapolating it to the mortality benefit, any intervention is actually maybe difficult in ICU setting, and to get only effect on mortality and mortality benefit with all other factors in place, which can cause increase mortality. So still there needs to be further studies to be done, but probably can we incline towards urine output criteria rather than a creatinine criteria is what I thought from this study we can do. And as whatever, still to extrapolate the same things into the clinical practice, I don't think I got anything from this study, but probably more inclination towards urine output criteria.
Yeah, so it will not change our practice at this point of time.
My take home would be probably not to just jump on the number of a creatinine and then probably dialyze the patients only because the creatinine is high. Yes, maybe urine output would be a better thing to do, and FST would probably be helpful.
Yeah, agreed. Okay.
So yeah, thank you. We'll meet next month with another trial and a new set of questions. Do subscribe for the YouTube channel of the Hicks group. Thank you, sir. Thank you, Lavanya.
Thank you.
See you
Thank you,
next
sir.
month.
Thank you very much. Bye bye. Have a good day.
Beautiful.